Hello, my name is Dimitar Semerjev. I'm a med student from Arkham Fort Smith, USA. I will be presenting our case report on non-operative management of acute appendicitis. Appendicitis is the acute inflammation of the appendix with a lifetime risk of 8.6% and 6.7% in males and females respectively. The current standard of care for acute appendicitis is appendectomy, which can be done via laparoscopic approach, robotic approach, or via an open incision. The alternative treatment for appendicitis is a non-operative approach, which could be used in cases of uncomplicated appendicitis and uses a combination of medications such as antacids, antiemetics, and oral antibiotics. For our case presentation, we present a case of a 20-year-old male that came to the ED with periumbilical pain, which migrated to the right lower quadrant. The patient was positive for rebound tenderness. The patient had pain in the McBurney's point. The patient was also positive for obturator sign and was febrile at 101.4 degrees. Imaging showed an appendiceal diameter of 0.69 centimeters on an abdominal ultrasound seen in figure 1 in the bottom left hand corner. Also, there was appendiceal dilation, wall thickening, enhancement and thickening of the cecal apex seen on abdominal CT on figure 2, once again in the bottom left hand corner. Using the Alvarado scoring system, a diagnosis of appendicitis was given. Non-operative management for the appendicitis was pursued in this patient, which included a combination of antibiotics, PPIs, antiemetics, and antiacid. The patient was given ciprofloxacin 500 milligrams BID for 5 days, metronidazole 400 milligrams TID for 5 days, domperidone 10 milligrams TID as needed for nausea, omeprazole 40 milligrams in the morning for acid reflux, citrasoda, a sachet TID with 500 milliliters of water for concurrent UTI. Upon 1 week in follow-up, the ultrasound showed a resolution of appendicitis in this gentleman. In addition, the patient had no physical exam findings indicating of any ongoing appendicitis. The patient reported resolution of nausea, vomiting, anorexia, abdominal pain, and fever. The reason we're discussing acute appendicitis is because it is a medical emergency that needs timely and accurate treatment to avoid complication. Even delayed treatment or non-treatment of acute appendicitis can lead to complications such as abscess formation, the development of enterocutaneous fistula, diffuse peritonitis, sepsis, and even death. The current standard of treatment for appendicitis is surgery, and once again, it can be done via a laparoscope, robotically assisted, or even via an open incision. However, with a surgical approach comes a few risks such as postoperative abscesses, hematomas, and wound complications. If the appendix resection is incomplete, there could be issues such as recurrent or stump appendicitis as well. In some cases, conservative, rather minimal invasive surgical approach can fail, which can result in an open appendectomy, which has a higher risk of iatrogenic injuries such as injuring the ilioinguinal or iliohypogastric nerve or even cecal perforation. Therefore, non-operative management can offer conservative treatment for uncomplicated appendicitis, which allows for the avoidance of unnecessary surgery and the associated risks running with them. This is also a great choice for resource-limited areas where laparoscopic and robotic surgery is extremely rare, and a non-operative approach can be used to treat a complicated appendicitis. Using the above-mentioned treatment regimen, a complete resolution of appendicitis can be expected. In the bottom right-hand corner, you can see the references that we use, and this project was done by Dr. Khalid, student Dr. Shahab, Dr. Faruqa, and myself, Dimitar Semerjev. Thank you.